What is now advanced base, this thing, management will be totally different next year.
Absolutely. Absolutely. It keeps changing.
Maran and Priyanka, there are enough pages who have joined.
Some are on the YouTube also. So maybe after 2-3 minutes we can start.
Yeah,
Yes.
we are ready.
Yes, sir.
So Dr. Mohite, they can start.
Yeah, they can start.
Please introduce yourself from your PG year and college.
Good evening, sir. This is Dr. Smaran, Junior Resident Pediatrics in MGM Hospital, Kamote.
Good evening, sir. This is Dr. Priyanka, Junior Resident Pediatrics from MGM Hospital, Kamut.
Now let's follow one thing. After you give the history, we break and then we stop sharing so that we discuss first the history. Then we'll go for clinical examination. Complete will listen to you and then we'll stop again sharing. We'll discuss it and then we'll go to the completion of case. Fine.
Yes.
So we'll listen to your complete history. Once you finish, don't go to your analysis interpretation. We'll analyze the case and then we'll go for further things. Right? Fine. You can start. It's exactly 9 o'clock. Satish, they can start now.
Yes, sir. Yes, sir.
They can start.
Yes. Four-year-old female, second by birth order, born out of non-consensual marriage, hailing from Uttar Pradesh, residing at Kharghar, reliable informant being father, presented with complaint of fever since 4 days, reduced activity and oral intake since 3 days, confusion and drowsiness since 2 days, vomiting since 1 day, prolonged bleeding from IV insertion site on the day of admission. Uh, History of present illness. Patient was apparently all right 4 days back when she presented with complaint of fever, insidious in onset, gradually progressive, moderate to high grade on touch, not associated to chill or rigor, associated with poor activity and reduced oral intake. There was confusion, irritability, and drowsiness, which is on and off since 2 days. Uh, Child also presented with vomiting, small to moderate in quantity, non-projectile, non-bilious, non-blood stain containing the food particles. There was no history of seizure, neck pain, blurring of vision, or a headache. No history of visual disturbances or deviation of mouth or nasal regurgitation. No history of focal neurological deficit or sudden loss of consciousness. No history of loose motion. No history of prolonged drug ingestion. No history of abdominal pain, distension, or dark colored urine. No yellowish discoloration of the sclera or skin. No history of previous blood transfusion. No history of easy bruising or joint swelling. No history of decreased urine output or puffiness of face. No history of any rash.
Rash should come earlier than many other symptoms because you're talking about fever and this thing. So rash could have been given a little more importance. Thank you. Yeah, proceed.
Past history, no history of similar episodes in the past, no history of prolonged bleeding in the past, no history of any other significant illness and prior hospitalization. There was a history of, in family history, dengue fever in mother and elder sibling, which did not require hospitalization 2 to 3 days back of the presentation of the patient. No history of bleeding disorders in the family. Antenatal history, registered and immunized pregnancy, routine supplements taken, regular ANC visits with routine ANC scan with no abnormality, no history of any ANC complication present. Birth history, it was a full-term normal vaginal delivery. Baby cried immediately after birth, did not require any resuscitation. Birth weight of 2.5 kg, and there was no history of NICU stay. Immunization till 24 months of age under National Immunization Scheme, and developmental history, all milestones achieved appropriate for age.
Yeah, I always mention, no, when you're saying development, you always talk about growth also. 4-year-old child, whether the child is so growth and also has to be mentioned. Whether a child is growing for a 4-year-old child. Okay, so we always give importance to development milestone, but about the height, weight, of course, we'll be telling in detail later. But in the history also, you can mention, no, whether the child is, the parents will say whether the child is having the same height and weight like any other 4-year-old child in the neighborhood, etc.
Yes.
Okay.
Okay, go ahead.
Dietary and socioeconomic history. Eats mixed diet, non-vegetarian food consumed once weekly. Diet history revealed caloric deficit of 330 kilocalorie per day and no protein deficit. 4 members in family lives in one room pakka house and municipal water supply. And according to the Kuppaswamy scale, they are socioeconomic class 4.
Now, just stop this. Just stop this. Yeah, go back to the first slide. Fine. So take symptoms one by one and tell us what you get out of it. Here is a 4-year-old female child with whatever birth history, hailing from UP but presently staying in Khargone. Fever since 4 days. How do you take this first history? Is it any relevance? If you have some more details of the fever from that history of fever details, can you come to some kind of a differential diagnosis of likely pattern?
Yes, so the infection in origin of the if infection like malaria, dengue fever, or typhoid, which can be presented with the fever.
So from this 4-day history of fever, what more you want to know about the fever to make some kind of, I would say, conclusion on likely underlying cause. So how does a fever of viral fever of 4 days will behave? How does malarial fever of 4 days will behave? How does enteric will behave? How does bacterial fever will behave? So is there any some kind of a pattern which is, so can you tell me something more about this fever?
So between viral and bacterial, between the interfebrile period, the kid will be active in viral, whereas in bacterial, the kid will be relatively not that playful.
And the bacterial fevers are more high grade as compared to the viral fever. And activity associated with the viral fevers are with the bacterial fever are like less active child as compared to the viral fever.
Very good.
So based on the enteric fever, it shows a classic stepladder pattern. So they will there'll be increase in the temperature and then reduce temperature, and then again there'll be increase in that case.
Okay, now that you are mentioning about the fever, stepladder pattern, etc., you could have given a little more detail about the fever. What was the onset? It was the same throughout the day and intermittent, remittent, and it's high-grade fever, or with the paracetamol or antipyretics, it has come down responsive. You could have mentioned a few more adjectives to that. Yeah.
Srinivasan sir wants to know in this child, how does the fever behave? Do you have the details of that?
So basically, in this case, the fever was continuous throughout the day, which was relieved on medication, but the action was only till the medication action lasted, and then again there was a fever spike.
Was it high grade?
So basically, the fever was undocumented, but they were saying on touch, it wasn't that high grade on touch, mild to moderate grade.
How was the child's behavior during the fever, in between the fever?
Very important. Yeah. It's very important. Whether the child, once the fever comes down, is more active, or it has been throughout, child is having limited activities. The behavior of the child when the fever is high and when the fever is coming down is better to mention. Okay.
Yes.
How was
So,
this child behaving?
so initially they were saying that the child was active during the interview.
During interfebrile period.
Yes.
Okay.
She used
And
to
now
say a lot.
on day 4, how was the child behaving?
Drowsy. The child was drowsy,
Okay.
intermittently irritable on day
Fine.
4.
Was the fever responding to paracetamol?
Yes, sir. The fever responding to the paracetamol.
Fine. Now, last part of it, how was the fever pattern on the 4th day? Was it fever subsiding? Was the fever spiking more?
The fever was not resolving, sir.
So you mean to say it was spiking more?
Yes, sir.
It was spiking more. So from this pattern, what is the likely cause of fever you feel?
Uh,
So it's more like a malarial or a dengue fever.
So malarial fever on day 1, is it continuous fever?
No, sir. There is a cycle of febrile and afebrile phase with sweating associated with sweating, and there is a shivering.
Chills and rigors are very characteristic. In most of the cases, of course, there are always exceptions.
Well, I mean, sir brought up a very important point. So what does chills and rigor tell you? Is
so
it malaria?
chills and rigors tells about release of bacteria in the bloodstream. Bacterium, whenever there's a
Parasites. When there is a release of parasites.
So you mean to say chills and rigors means malaria? Fever with chills and rigor is always malaria?
No, sir, not always.
Have you seen a UTI child coming with very high grade fever?
Absolutely.
Have you seen a viral fever coming with very high grade fever and chills and rigors? So chills and rigor only tells you that there is sudden acute resetting of the thermostat. So all these inflammatory pathologies, whether it is infective or inflammatory, they mount the fever by release of cytokines, and the cytokines will affect the hypothalamic thermostat. Depending upon how rapid you need to achieve that new set high fever, body will react to generate that fever. Now, body's physiological way of generating fever is 2 ways. One, by stopping the heat release from the body, which is done by peripheral vasoconstriction. And this is what causes chills. Because of vasoconstriction, the surface don't get heat, so they feel chills. And the second, by generating the heat by causing vigorous muscle contractions, and that causes rigors. So any cytokine pathology, any inflammatory pathology that causes very acute resetting. So now your fever is temperature is 98, and within next say 15-20 minutes I want 103, versus the other child who is gradually increasing to 103 in 1 hour. The other child won't give rise to chills and rigors, but the first one will, because the resetting requires very high. So chills and rigors only tells you this child, due to some pathology or his own genetic complexion, he has a tendency to reset very fast, and irrespective of the underlying etiology, he can generate chills and rigors. So chills and rigors doesn't mean malaria. It can be any inflammatory pathology. Fine, that's one thing. Now, fever patterns in first 4 days, as our teacher Dr. Ambedkar sir keeps telling you, on day 4, if you analyze the pattern properly, then you can easily make some conclusion about likely pathology. So in case of virus, most of them will spike high right on the day 1. Most of them along with some kind of prodromal symptoms. So respiratory virus will have cold, cough, GI virus will have vomiting, diarrhea. And they will have that continuous high grade in day 1, day 2, though the child is playing in between. And day 3, day 4, the fever starts subsiding gradually. Most of them are started playing on day 4, day 5. They are comfortable on day 5 most of the times. Bacterial infection can be of 2 types, non-localizing and localized bacterial infection. When I say localized bacterial infection, it's something like tonsillitis, it's something like bacterial pneumonia, it's something like UTI, upper UTI, which are localized to certain. And here there is a extreme tissue damage So severe cytokine release, and they have high grade fever right on the day one, with many times a localized symptom coming on day one, day two, day three. And if you don't treat it appropriately, they will keep spiking and go on increasing the spikes on day 4, day 5. So this is a child who keeps becoming sick and sick, and maybe on day 4 or day 5 may get complicated, like pneumonia may get into empyema, UTI may get into sepsis, something like that. Vis-a-vis non-localizing bacterial infection, like say enteric fever, okay, wherein it's a GI infection progressing to bacteremia. So on day 1, day 2, there will be low grade, intermittent, gradually increasing. That's why step ladder. Day 1, 9900. Day 2, maybe 101. Day 3 now starts spiking. That's typical. And day 4, they are sick and toxic. Okay. Vis-a-vis, you have got a connective tissue disorder. Very classically, there is intermittent release of cytokines. So they have classical quotidian fever, daily 1 or 2 spikes of fever, and in between fever, child is bang normal. The temperature touches the baseline. So by getting a proper detailed history of fever for first 4 days, on 4th day itself, most of the times, you have made your conclusion. And this child comes on day 15 with a complex kind of things. You are lost. You can't make out which disease this is. Go back to day 1, day 2. If the mother is intelligent to give you a proper good history, perhaps you will crack the case, right? So next time you take a fever history, go on to day 1, day 2. We used to call as ODP, onset duration progress. One of our teacher from Raipur, Dr. Agarwal, Savar Agarwal, used to call it as OTP. We are very used to OTP, right? One-time password. So this is one-time password for your disease diagnosis. If you take that OTP well on day 1, you will be getting day 1, day 2, day 3 fever. You will get the history. So here, perhaps what you're telling us is a high-grade fever continuing on day 4. So either you're looking at maybe a bacterial infection or a complicated viral infection, which is progressing. Fine. Let's come to Srinivasan, sir. You want to add something?
Yeah. Another factor is important, as he has mentioned everything. So you have to mention, no, fever since 4 days, reduced activity and oral intake since 3 days. So what happened? Whether they took the child to the hospital, because you have mentioned prolonged bleeding from IV insertion site. That means IV has been put in this thing, medical consultation. So I'm sure they won't have put themselves.
So was
on,
this child coming to
so
you
you have
from
to mention,
some other
no?
hospital?
Yeah. So you have to mention the link, the parents have taken the child to this thing, no? There are so many systems of medicine nowadays. So you have to mention whether the child was taken immediately on the first day itself to the doctor, or second day or third day with confusion and drowsiness. So what exactly confusion and drowsiness the parents have mentioned?
Just one suggestion. Can you rename your slide with the your names? Your HP I'm seeing. If you can rename them so that I can call you by your names. I'm seeing HP. Can you rename? You know how to rename? Okay, you go take the cursor on your slide on the right hand top bottom. You're seeing 3 dots. Click on that, and then it's pin. Okay, I think you can rename from your end. Just check whether you can do that. What's your name? You said?
Sir, Dr. Smaran and Dr. Priyanka.
Smaran and Priyanka. Fine. I'll just write down so that
they are doing well. Only thing,
yes.
You just mentioned 2 days child has been absolutely normal. Third day, mother noticed the child to be a little confused and talking irrelevantly. Confusion means in what way the child is confused, because sometimes they may have delirium or they may be talking irrelevantly. Okay, and then drowsiness you have mentioned since 2 days, and then vomiting for 1 day. Then you have mentioned prolonged bleeding from IV insertion. That means child must have been taken to a medical consultation where the doctor must have put in an IV, isn't it? So everything you mentioned in order with a little more details. Otherwise, of course, it's very good.
Smaran, tell me, this child was referred to you from some hospital or he came directly to your hospital?
Sir, actually, the child was taken to a private pathology. On the parents themselves took for some pathology on themselves to do some testing. There they had pricked the child, and they had noticed that while he was coming, the child was having that persistent bleeding from the site of pricking, sir.
Very important point. Yeah.
Fair enough. Fair enough. So then it's an appropriate history. Otherwise, if he comes directly to you and you notice there is prolonged bleeding, then that doesn't become history, because history is what the parents narrate to you. It's not what you detect subsequently. That's an examination. Fine. So now tell me, old is fever, and then subsequently comes with reduced activity and confusion and drowsiness since 2 days and vomiting since 1 day. How do you add these two histories to your initial 4 days history, and what interpretation you make out of it?
Sir,
What you can do is you can stop sharing so that others also can participate in the discussion. You can stop sharing and later on you start sharing again. Perfect. So other students also can unmute their video so that we can have a good, nice discussion. I'm seeing a lot of students, so they can unmute their videos
Yeah,
so that we
that's
can have
nice,
still
very
better
nice, yeah.
discussion. Yeah. So I'm seeing Dr. Preeti Ji, Dr. Priyanka, Pooja, Tanvi, they can unmute so that we can have a better discussion. They can
Okay.
all participate so that we can really enjoy it much more. Fine.
Yeah, I'm
So-
sure you will also be having ideas like us. You can always express. Yeah.
So let's come back to it. 4 days history of fever and 2 days history of altered drowsiness and then vomiting 1 day. Tell me, how do you connect these 3 dots and what is your interpretation?
sir, it can be of infectious origin like dengue fever, leptospirosis.
No, I want, see, whenever we analyze, we look for anatomy of the problem, then we look for what is likely pathology, and then we go for microbiology. See, that is how we are trained in our MBBS, right? First MBBS anatomy, physiology,
Yeah, you
then
already
second
mentioned,
MBBS pathology, microbiology. So
yeah,
tell
you
me
already
now.
mentioned a few
Yes.
symptoms which suggest involvement of some other areas, isn't it? Bleeding
Yeah.
means what?
So
The
tell
child
me,
is having
what is the
continued
anatomy
bleeding.
of the problem? When you say fever, followed by altered sensorium,
Yeah,
then headache.
confusion, irritability, you said.
So,
So
sir,
that
it will
means
be
some
meningitis.
mentation, altered mental status is there, isn't it? Not the same as his child was before the illness. So altered mental status is there, some neurological, minor neurological problem is there or disturbance is there. Okay, similarly, you said bleeding is there because continuous bleeding from the site where the blood was taken for test. Okay, that indicates that there is a hematological problem. Okay, like that, that's what Dr. Mahesh Mohite wants to tell you. Which are the other areas from your history? The it's not just fever, it has already affected some other organ system. Okay, it, not in a very serious manner, but in a subtle manner, which may become serious. Yes. Am I correct, sir, Dr. Makesh?
Yeah, you're right. So basically, what we wanted to tell you, Smaran and Priyanka and others, is this disease starts as a fever, which is an inflammatory sign, and subsequently within a day or two gets localized to some system. And here, perhaps with the altered sensorium lethargy, you are talking about localization to CNS. You may get cough starting on day 1, day 2. You may say it is localized to respiratory. Somebody starts with GI symptom, we say localized. So this, when you get this kind of a localizing symptom versus some patient have no localizing symptom or multi-localizing system, vomiting, loose motion, headache, cough, cold, everything. How do you differentiate about possible underlying pathology? So we talked about viral, bacteria and all. So how do you get a differentiation? Can you make some more comment on that?
Sir, on the basis of associated feature related to that anatomical site. Like in
Right.
this case, there is a altered sensorium and irritability and confusion. So it relates to the signs or like features of meningitis or encephalitis.
So features of meningitis versus encephalitis, are they the same? So this child is showing features of what? Meningitis or encephalitis? So what are the clinical symptoms of meningitis in a 4-year-old child versus features of encephalitis in a 4-year-old
Times, you
child?
know, with 11 speech. Okay, yeah.
Sir, like fever with neck pain and headache, that more likely a meningitis. And in there can be like altered sensorium in encephalitis.
Headache is a sign of what? Suppose it is neurological affection. Headache tells you what?
It tells about increase in the intracranial pressure.
Perfect. So that can happen in meningitis or encephalitis either. Is that right?
Yes,
Yes.
sir.
So what are the features of meningitis? When you say this is likely to be only meningitis, and when you say this is likely to be encephalitis alone,
It's a neck pain,
Neck
is
rig-
neck
Okay.
rigidity,
Neck
or
rigidity.
neck pain is
neck
most
rigidity is a sign or symptom.
It's a sign, sir.
Sign.
And
Perfect.
symptom
So
is
I'm
neck
talking
pain.
about symptom. Neck pain is okay. What else?
S- can be a
So
vomiting,
irritability.
irritability.
Irritability, right? Headache may or may not be there. Irritability, neck pain, and photophobia. It's quite common. Okay. So those are the ones. Invariability is associated with some headache and vomiting, which is a sign of raised ICP. And when it is encephalitis, what are the symptoms? So the symptom related to gray or white matter, what are they?
The neurological deficit or altered sensory.
Altered sensorium. So what are the findings or symptoms of gray matter? It's an altered sensorium or seizure. When the gray matter is affected, child may come up with seizure. Later on, he may come with focal deficits. Okay. So these are the features of gray matter, which is suggestive of encephalopathy, or in the infection fever, it will be encephalitis. So this child is showing what? Meningitis or encephalitis?
Encephalitis. So because there is-
Perfect. So you have got probable infection giving rise to encephalitis and probably raise ICP because now he started vomiting also. Fine. Okay. And then on that background, as Dr. Srinivasan sir said, that there is a bleeding tendency. So what does it tell you?
Sir, it can be a bleeding disorder associated with it or coagulation, coagulopathy.
So
Or
is this a congenital bleeding disorder or
can be
acquired?
infectious
Acquired,
related,
sir.
like sepsis. maybe.
Fine, fine. So now you have definitely two systems defined in this child. So what are we dealing with?
So one can be a CNS system and one can be a hematological system. Apart
Yes.
from that, so because we have a family history where the mother and the elder sibling also have dengue and they presented during the month of monsoon and they have history of fever. So we can also suspect infectious origin like dengue or malaria.
Perfect, perfect. So malaria. Why you said
Yeah.
malaria? What are the features of
Malaria
malaria?
breeding is not that common, especially with this presentation. We have to consider platelet
Okay.
deficiency or platelet functional disorder. So it's very important that.
Rarely
we are
complicated
considering.
malaria can behave,
Yeah,
but again you need to know the epidemiology. So in a
that
New
is
Bombay
called
is
black
coming
water
from.
fever. Okay,
Yes,
that is the
yes.
hemoglobin fever.
That will come more like a shock, hemolysis, intravascular, extravascular hemolysis. Okay. And presently, are we seeing that kind of a cases from the Kharghar belt and the New Bombay belt? What is more rampant, malaria or dengue?
Dengue.
Are you seeing malaria cases off and on?
No, sir.
Perhaps not, right? So that is also important. And this presentation, yes, cerebral malaria can come like this, but less likely at this point of time. So looks like probably dengue. Can it be any other infection? Can it be TB? Can it be tuberculosis?
So no history of prolonged fever or low grade fever, and like and
Okay.
no history of weight loss. So and no family history of TB also. So less likely
Yeah. So
suggest.
contact history is very important, and rest of the thing is very acute. That is a bit unusual for TB. That is something more likely to be an acute disorder like a dengue fever. Okay. What other positive history you gave? Yes, sir. Sir, unmute yourself. Srinivasan sir, please unmute yourself.
One point
Yes.
against that is that a bleeding tendency has been there. We have specifically mentioned, which is not a common thing in tuberculosis.
Not a common thing. Yes. So what are the other positive findings? Can you go back to your presentation once again? Start sharing. You gave us a lot of negative history. So just one by one, please clear one by one those histories. Go to the negative history. Yeah, go to the next slide. Next slide, please. Yeah. So neck pain, blurring of vision, visual disturbances, focal neural deficit, loose motion, Okay, why you asked about loose motions?
Because there was fever with vomiting, so ruling out if there
See,
is
one thing.
type.
Last time we have discussed this. The negative history is kind of an history we need to get by direct questioning to the mother or whoever is giving history, and that should be relevant and precise. Relevant and precise. Otherwise, you can ask 100 questions, right? Whether he's having backache, whether he's having limb pain, whether he had a accident, we had a trauma, he traveled to some place. You can ask anything. That's not a negative history. From the primary complaints, like in this case, it looked like encephalopathy, encephalitis. Okay. So negative history will be relevant to that. So did he travel in the recent time
No,
to any
sir.
place? Because what are the other differential infections, infection differential diagnosis in this case? When you said dengue, can it be scrub typhus? Scrub typhus can present like this, right? So has he traveled to any epidemic zone? Is he staying in the rural area where those mites are there?
No, sir.
Any pets are around? So those can be a negative history. Okay. You rightly asked about the contact history. Parents suffered from dengue. That's so important. So this is relevant history which mother may overlook, or she may feel this is not important, but for you it is important. So ask the history which is relevant to the case and important for diagnosing. It's not just narration of 100 negative things. That's not a negative history. Fine. Yellow is discoloration, right? Previous blood transfusion. Why you ask previous blood transfusions?
So most any like blood transfusion related viral infection transfusion to the blood and causing,
Which are there?
so like hepatitis C or
So do you think
malaria.
that kind of a history will
Malaria
come
also.
as acute, hyperacute?
So most likely hyperacute it is.
Exactly. So what I want to again, no easy bruising, joint swelling. Now, all these histories, if they are there, generally mother would tell you, she won't miss it. This kind of a relevant history. Why I'm asking you, see, you asked few questions and I started countering you and the whole case will go on to wrong track. And you will be missing the core of the case. In exam, time is equally important. Don't allow the examiner to take you off track. Many times we say as an intelligent student will guide the examiner, not that examiner will guide the student. Srinivasan sir with a vast experience will tell us this.
No,
So,
experience is even though every day is an experience for us. Yeah.
yeah.
So what is
Okay.
important is if you are thought of hepatitis, you could have mentioned about jaundice, and then of course you could have
Okay.
mentioned, because
Let's go
usually
to the-
jaundice will appear on the third day, fourth day
Yeah.
before this thing. So,
Sir
yes.
asked about the rashes.
Yeah,
Which kind
mentioned
of rash you are
subsequent.
asking? Sir asked about the rash. Which kind of rash you are want to ask in this child? What kind of rash did you ask for?
So blanching rash, the dengue fever
Of
mostly.
course, he has already mentioned about scrub typhus.
Yes. So blanching rash. Scrub typhus rash. What type of rash is it? Have you seen a scrub typhus?
You'll find
Rickettsial fever?
Thick skin. Yes, sure. So
Yes,
in
issue is there.
some hidden areas you may find, if you very carefully look for, you'll
Right.
find some evidence.
Right.
Yeah.
And more, that you have to search, but classical thing will get to the vasculitis rash, the palpable purpura. The pathology goes with predominantly small vessel vasculitis, which will be palpable purpura. And yes, if you get a issue, that's a pathognomonic diagnostic feature of rickettsial. So that is what is important, right? Go to the next slide. Next slide, please. Yeah, past family history, we'll leave it. Next slide, please. Okay, here it's okay. Go to the next slide. Sir already mentioned about development. Along with that, you asked for the growth evaluation of the child. And I'm sure that you will be going in your examination also. We'll not go to the others. We'll go to, next slide, please. Diet and socioeconomic. When you feel it is not very relevant or you feel everything is okay, don't waste much time. You can say his requirements is so much and deficit so much, calorie and protein, and just go to the next slide. If examiner is concerned or is finding something, he will ask you questions and be ready with this kind of details of it, right? Otherwise, you will be again wasting time on this. Right, sir? Srinivasan, sir, what do you think about this?
Yeah. Yeah,
Right?
absolutely correct, because we have
Yeah.
mentioned now specifically 4-year-old child, the
Yeah.
calorie expected itself is less. Okay, so usually you'll find about 4 years, 90 calories per kg. So 4-year-old child will be about, what is the weight of 4-year-old child? About 16 kg, 15 to 16 kg. So definitely child is getting less calories, yes.
Fine.
Proceed.
Okay, go ahead. Yeah, so tell us about the impression now.
Sir, a 4-year-old previously well, completely immunized girl with normal birth and developmental history presented with acute onset febrile illness with reduced oral intake and activity. Vomiting and altered sensorium can be a most likely a case of infective etiology either involving the CNS or the GI system. Could be a case of meningitis, encephalitis, viral hepatitis, dengue, malaria, and leptospirosis.
Fair enough. You need to be slightly more precise in your things. I know you already defined encephalitis in this child. Meningitis, perhaps I may not be giving. I'll rather call it as an encephalitis. Probable cause of infective encephalitis, which may be dengue or malaria. Leptospira. Why you said leptospira likely in this child?
Especially with your typical with the typical history of bleeding from the vellum puncture site. You must not think of meningitis, encephalitis. Meningitis sometimes occasionally DAC can occur, but not in the initial stages. So it's better you think of some condition that is a possibility of platelet deficiency or platelet functional disorder or this thing. Meningococcemia can cause, of course, hemorrhagic rashes, etc. But they'll be very serious cases. Okay. So here I think you have to change the order of your this thing. I don't say you must not consider meningitis and encephalitis, but especially with your family history of dengue fever and especially bleeding tendency, you have to think of
Perfect.
dengue as an important possibility.
Yes,
Then,
yes.
of course, you will think of other conditions.
Right, right. So have you seen, do you think a bacterial meningitis can present like this? Have you seen viral meningitis cases? Do they behave like this?
Yes, but not we have that bleeding tendency is not that common.
Isolated viral meningitis children rarely or almost never become toxic. They are transient, fever for 2-3 days, headache, vomiting, and they are home on third or fourth day. Bacterial meningitis can become sick, okay? But again, the bleeding may not be a classical point in that. So it looks like encephalitis, very likely
Encephalitis
viral
convulsions, of course.
Yes. So this
Altered
is
symptoms
looks
will be
like
much more advanced, and also convulsions will be there.
And as sir said, there is a strong family history of contact, and the child comes with bleeding manifestation with the encephalitis. So I will give very pinpoint, probably dengue encephalitis, and then I can give 1 or 2 more differentials. Okay, viral hepatitis coming like this with fever, altered sensorium, headache, bleeding. Okay, which viral hepatitis behaves like this? Can it be hepatitis A behaving like this?
No, sir.
It can, but it's very rare to come like this.
Not.
It can. Okay, you can have hepatic encephalopathy or encephalopathy because of hepatic failure, but not that common with this kind of a presentation. Typical thing will be by this time they will be presenting more for jaundice. Rarely you can have Ray's syndrome coming like this, which can behave like this. Fever followed by encephalopathy, vomiting, and jaundice may not be there. It's the anectic hepatitis. Okay. Now 4 years old with Ray's syndrome, quite often it's underlying metabolic problem. But what I want to say is try to be more precise. You can always give a justification. Sir, this child has got a strong family history of dengue and has come with bleeding and encephalopathy. So it could be dengue encephalitis as my first differential. And second, I will have to give a differential, another maybe malaria I can give here. Or could be a scrub typhus. I might as well put with the endemicity, scrub typhus as another differential diagnosis. Meningitis, I may not be giving it. Are you okay with that?
Yes, sir.
Fine. Let's go further. Yeah.
On physical examination, so general examination, when the patient presented, patient was febrile with a temperature of 100 Fahrenheit, heart rate 120 per minute, respiratory rate 30 per minute, saturation 98% on room air, BP 94/62 mmHg. Peripheral pulses were well felt, central pulses were well felt. CRT was less than 3 seconds. And no pallor or icterus cyanosis, clubbing, no lymphadenopathy, no edema.
Okay, go ahead, complete your examination.
On head-to-toe examination, eyebrow eyelashes were normal. Conjunctiva, no pallor, no redness, no suffusion. Sclera was normal. Abdomen, no abdominal distension, spider nevi, no blanching rash. Limbs, no tremor or petechia or ecchymosis. Spinal examination was also normal. On anthropometry, the weight for age for the patient was -2 to -1 standard deviation. Height for the age lied between -2 to -1. BMI was -1 to 0, and the head circumference was a -2 to -1. Mid-arm circumference 13, and chest circumference 46 centimeter.
One
On
minute,
sys-
1 minute. Interpret
Yes.
your anthropometry.
So weight for height, weight for age and height for age being between -2 to -1 standard deviation.
Priyanka, just one kind of a suggestion, Priyanka and Smaran both. When you're presenting online, it's easy to put up a growth chart, that can give you a much better visual impression than these numbers. So now this child is showing almost 2 standard deviation, 16 kg is expected and is less than 12 kg. Okay, so by IAP standard, do you think he is malnourished? What are the IAP guidelines for malnutrition?
So
So-
weight for age should be less than -3
Minus
standard
10.
deviation.
So generally less than 80% of the expected, right? So this is obviously less than 80%. So easy malnourished, easy failure to thrive. Srinivasan sir, you are muted, so we cannot get you.
What is the birth weight of the child?
So 2.5.
Yeah, so it will be, 3 times at 1 year and 4 times. It becomes 10 kg. And then after that, every year child will have 2.5 to 3 kg. The child is having only weight of 2 kg. That's why I asked, you must give importance to growth also. Not
So
only
growth
development.
chart is very important
Yeah.
here. And going by IAP, this looks less than 80% of the expected. So do you label him as failure to thrive?
No, sir.
Why not? It's below 80% of the expected. Below 80% of the 50th percentile.
Body must be like-
So what is failure to thrive? That is why again you need to have the growth chart. What is the height expected and where it stands? That also is below 2 standard deviation, right? His expected height at 5, his 4 years, so 102 you gave. Okay. And he's at 92, which almost comes to 3rd percentile. So when you label it as failure to thrive, rather it is weight for height which is to be taken into consideration. Now, if you take 11.5, this height or 92 centimeter, this is expected height for a 3-year-old child. And the expected weight for 3-year-old child is approximately 14 kg. Now,
What do you
if
think
you are,
about the head circumference? Even head circumference 35 centimeters at birth and 10 centimeters child will gain in the first year. It will become 45 centimeters, but at 4 years child is having only 47.5 centimeters, isn't it? So that is also less, yes.
we're just putting one point of failure to thrive. So here, his height is appropriate for 3 years child approximately. The weight expected at that is somewhere around 14 kg. And going by IAP chart, if it is less than 80% of the expected, so here if it is less than 11 kg, 14 ka 20% is about 3 kg. So below 14 is below. So if it is less than 11, then we will label it as failure to thrive. Here, by those criteria, it doesn't fall into failure to thrive. That is where sir was telling you to ask about the growth as well. So the interpretation of this is probably not a failure to thrive. It falls into, so either short and the wasting. So whether it is chronic malnutrition, perhaps we'll have to go
Yeah.
more into
It's
charts
a
and all.
definite nutritional
Yeah.
deficiency.
Yeah, right?
Yeah.
Go ahead further. Sir also mentioned about head circumference. At age
Yeah,
of 4
proceed.
years,
Next
you
slide.
wanted head to be somewhere around 51 centimeter around. So that is low, but maybe still falling into third percentile. Okay, go ahead further. Yeah.
On systemic examination, on central nervous examination, a higher function test, sensorium, it was alternate irritability and drowsiness were present. Speech was normal, memory was intact. Motor system examination, posture, the patient was lying comfortably on the bed. Coordination and gait could not be assessed due to the altered sensorium, and the patient was not complying to the commands. No involuntary movement or tremors, no nystagmus. Cranial nerve
No,
examination.
One minute,
That's
one
the
minute.
previous slide.
Go back.
Yeah, go back. You said, the child could not be assessed due to altered sensorium, but memory, how did you test? You
There is
said, no,
speech, and speech is also
coordination
normal.
and gait, you could not assess due to altered sensorium. But how could you test memory when there is altered sensorium?
So
Okay.
basically,
So don't
Yeah.
give inconsistent things, okay? Because, if the child is having altered sensorium, we will not be bothered about memory. Okay, that is usually not tested at that time. Yes.
Priyanka, you were
Okay.
saying something. Priyanka, you wanted to say something. What was that? How you could test the memory in this child?
so basically, whenever the father used to talk to the child, so when she used to ask, "Do you want to go to school? You want to go to school by auto or bus?" To that, the recent memory she used to respond that I want to go to auto, I want to go by bus, I want to meet my brother. So,
See, generally, when you say drowsiness, you're talking about GCS dropping down to 13, 12, something like that. Okay. That is not, that also tells you gray matter affection to some extent, a cortical
even-
dysfunction in a false language.
And when the
with that,
child is
you don't
irritable,
expect- yeah,
when the child is irritable, even if the father or mother asks, they may not tell relevant answer.
yeah.
They
So-
may be so irritated,
that-
they won't give the proper answer.
That's not the right history. Okay. So be confident. Once you say altered sensorium, all those other functions have to be affected, and don't mention even if you are sure about it. Don't mention about it. Yeah. Go to the next.
cranial nerve examination. The cranial nerve 1 could not be assessed. Cranial nerve 2, gross vision was normal. 3, 4, and 6, eye movement in all directions were present. Direct and consensual light reflexes were present. On cranial nerve 5 examination, there was no pooling of saliva. Corneal and conjunctival reflexes were present. Cranial nerve 7, no facial asymmetry, no deviation of angle of mouth. Cranial nerve 8 could not be assessed. On 9, gag reflex was present. Palatal reflexes were present. 11, shrugging of shoulders were present. And on 12, movement of tongue was normal. Bulk and size of the tongue was normal. In general, the cranial nerves were intact.
Okay.
On motor examination, the bulk was normal. Posture of the limbs were normal. Nutritional bulk normal of all the 4 limbs. Tone normal in all the 4 limbs. Superficial reflexes, abdominal and plantar reflexes were present. Sensory, superficial sensation, touch, pain, temperature preserved. Positional sensation, vibration, and positions were intact. Reflexes, all the reflexes were equal and present in bilaterally. Power were 5 by 5. Bilaterally in upper limb and lower limb. There was no neck
Yeah,
rigidity.
just go back to the slide previously. Position sensation. How you checked vibration and position intact? In a 4-year-old child, how will you check vibration and position sensations? What does it tell you? Vibration and position. Position is also called as what? What does it tell you? First of all, why you want to test it? What does it tell you? Vibration and position, they are checked in group. But where is the pathology? And how do you elicit that? And what does it tell you?
Sir, the position and vibration in the anterior column of the spinal cord. The
No. That
Sir,
is
I want
not
to tell one important point.
right, sir.
Because nobody in this case, none of the examiners, none of the students will be examining for vibration position in this child with this particular history. I'm sure it has not been done. So don't tell
Absolutely.
something which you are not doing in a child. Okay, will be caught
Generally,
unnecessarily.
yeah.
Yeah.
As sir said, at age of 4 years, it is very difficult to elicit,
And
even if
especially
the
with
child
this
is,
thing, yeah.
sensorium wise totally normal. Even if the child is sensorium intact, it's very difficult to elicit. So generally, we will elicit beyond 7 to 8 years where the child is absolutely conscious, alert. Now, position, that is also called as proprioception, okay, and vibration and deep touch. So pressure, vibration, and proprioception, these go through, as Poonam Sawant has already mentioned, goes through dorsal column, also called as fascia cuneatus, and those two, which is the dorsal spinothalamic tract. Okay. Lateral or anterior spinothalamic tract gives you pain, touch, and soft pain, soft touch, and temperature. So these are the fibers which cross in the spinal cord at the same level of entry, and then they ascend and relay in the thalamus on the opposite side. And these posterior columns, the deep touch, which also called as pressure, proprioception, and vibration, they will ascend on the same side of entry, and they will decussate at the medulla to again relay on the opposite side of the thalamus. Fine. And these fibers are pathognomonic of certain pathology like B12 deficiency, or we olden times used to call as TBS dorsalis. That's a syphilis. Nowadays we don't see, and that too in adult age. So in a pediatric, really you don't get much information.
Yeah.
One
In
more
this
place
child
will you
is-
get? Yeah, one more get. We talk about sensory ataxia. Okay, so if
In
a
this
bigger
child, it
child,
is relevant, yeah.
yeah, this child
And
is not
honestly,
relevant.
I'm asking you, did you really test it?
No.
Be
No.
honest.
No, they are
Okay,
not. They are not definitely.
yeah,
So
yeah,
sir
yeah,
has caught you
definitely,
rightly.
yeah. No,
Sir-
that's what sometimes,
Yeah.
people will be very
Don't.
appreciative of your presentation.
and-
Suddenly, when you make something like this,
Yes.
then they will get upset.
And
Yeah,
if you have done it, then you should be able to explain what you're talking. Otherwise, you will be caught very wrong-footed. You have neither done it, you don't know it, then don't mention it. It's not right. Okay.
when you
First
say
of
child
all,
is having altered sensorium, how can you test this?
yeah.
Yeah,
And first of all, sensory examination in a pediatric patient below 5 to 6 years is, believe me, it's in a sick child, it's very difficult to appreciate. And you are kind of exempted from that particular test if you say that could not be tested at age of 4 years with this symptom, right? Fine, go ahead.
There was no neck rigidity, no meningeal signs present, no signs of raised diacity, and spinal examination was also no.
Okay.
On abdominal examination inspection, shape was protuberant, umbilicus retracted and inverted, no abdominal distension, no dilated veins or scars over the abdomen. All the quadrant of the abdomen move equally with respiration. On palpation, superficial palpation, no local rise of temperature, soft, no tenderness, guarding, or rigidity. On deep palpation, liver was 3 centimeter below the costal margin with rounded borders, smooth surface, with soft to firm consistency, tender, non-pulsating, and with a liver span of 7 centimeter. Spleen just palpable, smooth and soft in consistency, non-tender. On percussion, resonant all over the abdomen with liver dullness over the right hypochondrium. On auscultation, normal bowel sounds were present. Respiratory system, air entry was bilaterally equal and clear. Previous examination, S1, S2 was normal and no murmur was appreciated.
Was there any evidence of free fluid?
No, sir.
No, sir.
Is it relevant in this particular case?
I couldn't hear you, sir. What did you ask for?
Free fluid, evidence of free fluid
Okay.
in the abdomen.
Yeah.
Yes, sir. It
Is it
can.
important?
Yes, sir. You can, if it is a dengue-induced hepatitis and which is released to the liver failure, which can lead to the ascites. which is called the encephalopathy. So this
So
might
dengue ascites is because of liver failure, you mean to say?
the shock syndrome, dengue shock syndrome also.
So it is a leaky phase. Again, Dr.
Yes.
Poonam has responded. It's a leaky phase everywhere. So where else you look for fluid on clinical examination?
Pleural effusion, sir.
Perfect. So you need to mention if you are suspecting that as a pathology, that there is no free fluid in the abdomen. And in the respiratory examination again, there is no evidence of pleural effusion. Fine. Okay, go ahead.
And you have
No,
bleeding
no,
tendency,
no
always
examination.
examine the fundus also. Sometimes
Yes.
fundus may have some hemorrhagic spots, or oral cavity may have some the thing petechiae
Yes.
in the palate. So always mention those things. Okay, yes.
Yeah, I understand. But again, I mean, this is another 2 years old. I mean, this is a 2 days lethargic signs of fundus can give you good information about the intracranial pressure also. So what sir said is absolutely right. You'll have to mention. Obviously, I don't know how many postgraduates now do the fundus examination. Have you ever done a fundus examination? Have you attempted? It's good idea to have a fundoscope of our own at this time. Otoscope, fundoscope, we must have. Start doing it now in your PG days only, so that it will be a kind of a long-lasting training, and they are very useful things when you go to periphery. You can't send every patient for a CT scan. So this is some bedside methods.
You must always carry a otoscope and ophthalmoscope. It is part of your armamentarium.
Yes, always. Okay. So fine. So now sum up your case with the history and examination. We won't go for investigation immediately. Tell me what has the examination added to the history that you gave us?
Sir, it can be the dengue fever with.
What are the features of dengue fever you got on examination?
With dengue hepatitis, like sir, hepatomegaly.
Okay. Okay. But I don't have jaundice, right? What is the hallmark of hepatitis in a pediatric patient? Is this hepatitis? You feel this is hepatitis? What is a clinical feature of hepatitis?
Icterus, sir.
So is he having icterus? You said there is no icterus, right? So where is the hepatitis?
It can be, sir, anecteric hepatitis.
So dengue has an anecteric hepatitis?
No, sir.
And his altered sensorium is due to what you feel? It is encephalopathy, hepatic encephalopathy? What is the cause of his altered sensorium?
Could be hepatic encephalopathy, sir.
So again, he's having bleeding, so that may go in favor, but there is no jaundice, right? So anecteric hepatitis is not a presentation of dengue hepatitis. If you're calling it as a viral hepatitis, probably dengue encephalitis with hepatitis, then usually hepatitis of dengue will be icteric. So can there be a dengue pathology giving rise to hepatomegaly?
No.
Why you get hepatomegaly in dengue? He's having hepatomegaly, which is tender hepatomegaly, right?
Yes.
So what is the cause of hepatomegaly in a dengue? First of all, tell me why you get tender hepatomegaly. You have got a chronic liver disease, large, almost 6-8 centimeter, and that is not tender, right? And this is just 4 centimeter and tender. Why you feel this hepatomegaly is tender? Tanvi has responded, it is because of stretching of capsule. But Tanvi, stretching of capsule there in a child with a 10 centimeter liver also, which is chronic hepatomegaly. Why that is not tender and why this is tender? So hallmark is this is acute enlargement of liver. Tenderness you will get when there is an acute enlargement. The one which I am telling you about chronic liver, that has happened over years. So there is slow progressive stretching to which the capsule is adjusted. Here within hours, within days it is stretched, so you get the tenderness. Okay. So this denotes it's only stretching and large size of the liver. So large size of the liver doesn't always mean inflammation. If there is a capillary leak in the liver parenchyma itself, that will cause hepatomegaly, and that's one of the commonest cause of hepatomegaly in acute dengue fever. Right? Similar thing you get without liver. Can you have, which are the other causes of hepatomegaly without liver cell affection? Acute hepatomegaly without liver affection. Just for the sake of understanding, which are the other hepatomegaly, which are tender hepatomegaly, but not an infective hepatitis. So Tanvi again saying, yes, CCF, somebody saying constrictive pericarditis again may not, because it's a slow progressive, but you can have Budd-Chiari obstruction. Okay, so any vascular obstruction can give rise to. So liver, when we talk about, we are having a liver cell, you've got reticular endothelial cell, you've got biliary component and vascular component. Any of them suddenly increasing will give rise to tenderness. So it could be vascular, as they said, CCF, yes, Budd-Chiari acute, yes. So they all can give rise to tender. But here we have probably viral hepatitis like or viral encephalitis like picture. So, and on the background of dengue, so it's a capillary leak or acute inflammation and capillary leak that is causing. And that's why perhaps you don't have a jaundice coming up. It's only a tender hepatomegaly. Fine? Okay. Now you summarize the case with your, anything else you got on the history which will, or examination which will help you in diagnosing the case?
No, sir.
Okay. Okay. You were giving some short forms which you avoid in the exam, PICCLE. I'm sure every institute has its own short forms, but avoid them when you're presenting in the examination. You go into proper details of it. Fine. So sum up your case now, then we'll go for the investigations. Smarad or Priyanka? Yeah. Yeah.
4-year female with history of fever since 4 days and altered sensorium and with bleeding, increased bleeding tendency and with hepatomegaly, tender hepatomegaly, most likely due to the dengue fever, viral dengue related encephalitis.
Okay. So dengue multi-organ affection, dengue encephalitis with the bleeding tendency with hepatic congestion, hepatomegaly. Fine. Okay, let's go for the investigations. Srinivasan sir, you wanted to say something? Srinivasan sir?
No. Everything is
Okay.
fine. Yeah,
Okay,
yeah.
okay.
We have
Okay.
discussed everything in detail. Yeah,
Yes,
you
go
can
ahead.
go ahead.
Yeah. Okay.
Sir, on admission, baseline investigations were noted, and on CBC, the total counts were 1,950, platelet of 1.08, HB of 12.8. On LFT, the SGOT and SGPT was significantly raised, 8038 SGOT and SGPT 2098. RFT was within normal limits. The coagulation parameters, the PT was 16.3, INR 1.14, EPTT 112, and ammonia was also raised, that is 122.8.
Fine. So interpret these on the background of probable dengue.
So there is leukopenia, there is thrombocytopenia, there is raised transaminases, hyperammonemia with a deranged APTT. So based on this, sir, it can either be dengue, it can be either viral hepatitis, or
Can be a dengue-induced hepatitis,
Okay. Okay.
and it can be a sepsis with induced coagulopathy.
Can the same thing be due to strep typhus, which Dr. Mahesh has mentioned earlier? Leukopenia, neutropenia, and then this thing, again, enzymes elevated. It could occur in as well
Have you
in
done
strep
NS1?
typhus also.
Have you done NS1 in this
Yes, sir.
child?
yes,
NS1.
yes,
Is it positive?
It was
no,
negative,
it
sir.
was negative.
What about IgG, IgM?
It was
Second, we have included that in the next slide. So can I go to the next slide?
Yeah, we
Okay,
want,
okay.
then we'll come back to this slide once again.
So basically, as the investigations were suggestive of leukopenia, thrombocytopenia, transaminitis, hyperammonemia, and deranged APTT, hence fever profile was sent where we checked for malaria, dengue titers, Hep A, E, B, C, typhoid, leptospirosis, and everything was reported negative. Because the APTT was significantly high of 122, that's why factor assay was sent to rule out coagulation disorder, as APTT was out of proportion along with prolonged bleeding from the prick site. But clinically and hemodynamically, the child was stable, and even factor 8 was reported as within normal limits. The D dimer, sir, was on the raised D-dimer were raised. So basically, we were suggested that once the D-dimer reduces and the sepsis settles, to repeat the coagulation profile later. Then progressively, sir, liver enzymes and ammonia showed a reducing trend. Yet the child had a persistent fever spike with a falling count. So we suspected HLH, and hence inflammatory markers were sent, which showed a raised ferritin of 10,000, raised triglyceride, and we did a bone marrow biopsy on which hemophagocytes were seen, after which patient was started on injection dexamethasone according to the HLH protocol, and patient showed a significant improvement. Further, we did a CD64 marker, which came to be negative, and later for ruling out if there was any secondary cause for the HLH, we did a EBV titers, which came to be positive for both IgM and IgG, and hence finally a diagnosis of HLH secondary to HBV infection was made.
Go back to the previous slide. Now, 2-3 things. Your history and primary presentation doesn't fit into EBV infection in this child. Okay, 90% of the EBV infection will come with tonsillopharyngitis as a presentation, then we'll go on to multisystem, and usually the progression is not so fast, though I agree that EBV can give rise to hyperferritinemia related to HLH. Second, on the background of dengue in the family and the subsequent pathology that you described with acute encephalitis, with a bleeding tendency and everything, we would still call it as dengue. Now, there are cases on report where NS1 came negative, and there we go ahead and do the PCR of a dengue virus. And that gives you much better clue. Where IgG, IgM also may not. So there is a window, like you do NS1 between 1 to 5 days, then that becomes positive, and after that NS1 becomes negative. Later you do it, more likely it will be negative. And there is a window in which you will have only IgG positive.
People have seen.
Yeah, you will have only IgG positive, not even NS1 or IgM. That only tells you it was a previous dengue, which this is a secondary dengue, and IgM may take another few days to come up positive. And therein, when we strongly suspect in today's era, we do dengue PCR. That gives you a definitive clue. Now, EBV presenting in this fashion, yes, EBV can give rise to HLH. In fact, on this slide itself, I was almost sure it was HLH. We are asking about ferritin and all. Now, dengue per se, by virtue of the viral infection of dengue, has recorded very high ferritin without a classical HLH presentation. Okay, so there, as a set, you have to do ferritin, triglyceride, and a fibrinogen collectively to make a diagnosis. Your bone marrow evaluation is not a mandatory to diagnose HLH, because that is one of those 8 parameters that though we don't do the CD25 and NK cell activation. But here, overall picture looks like HLH. Second, SGOT-PT above 1000 in multiple thousand. If I have to take that high transaminitis, there are only 2-3 differential diagnoses. One is ischemic hepatitis, which is very common occurrence with a dengue hepatitis. Second, it could be toxic hepatitis, that is some kind of a metabolism or kind of allergic reactions which can give rise to. And third, of course, the infective hepatitis. Rest all. So dengue hepatitis per se or EBV hepatitis per se, they won't give rise to such a high OTPT. Again, OT more than PT tells you it is a non-hepatotropic virus. It's not a primary hepatotropic virus. So a lot of inputs in this. APTT going so high, without PT being high. That's again unusual. If you're talking about hepatitis, I wanted to have both hand in hand. If I get this kind of a discrepancy, I say this is a fallacy of the report. This report is not to be taken as a valid, because this report is more like a coagulopathy. Like if you do it in case of your factor deficiency, okay, factor 8 and all, you will get this report. What case you are presenting is of the hepatitis, whether it is HLH, whether it is primary viral. In that case, I expect PT as well as APTT both deranged. Here, PT normal and APTT deranged is not a feature of hepatic cell failure or hepatitis. It is a feature of only clotting factor deficiency like hemophilia. You will get this kind of reports. Okay. Third, you are having bicytopenia. Here, probably hemoglobin is raised to probably was in shock at some point of time. This child, did
No,
he
sir.
ever develop hypovolemia, shock, anything?
No, sir.
You did not. Okay. Because otherwise you could explain this as pancytopenia where hemoglobin goes up because of shock. The rest of the parameters are low because of the viral suppression. Okay. So I do agree with the diagnosis of HLH in this child. About the EB virus, I will take it with a pinch of salt because EB virus is ubiquitous.
Yeah.
And you can have it in patient false positive.
Because,
That may
there is
not
no
be the
specific
cause of the
reason.
whole scenario. Okay. Somebody, Tanveen is asking, sir, can dengue causing
There are no
endothelial? What is
markers,
that?
either examination. Yeah, during examination also, you didn't mention any lymph nodes and throat. You haven't mentioned about this thing. So there
Yeah.
were no markers to suggest infectious mononucleosis.
So I think Tanvi has asked a very good question here. Sir, can dengue causing endothelial dysfunction cause a raised APTT? So can you take that question? She has got a very good question here. Can just endothelial dysfunction give rise to raised APTT? Again, endothelial dysfunction will activate the intrinsic as well as extrinsic factor subsequently. Today, in the today's era, we don't consider these two things as separate. It's in fact, now it's a IAP, that is initiation, activation, and proliferation. We no more call it as an intrinsic pathway and extrinsic pathway. It is initiation, activation, and proliferation pathway. And in all, both the intrinsic and extrinsic pathways are involved. And when both are involved, you expect APTT as well as PT both to be deranged, not just. So maybe you have got an endothelial dysfunction that will give rise to derangement of all. So you take something like a HUS, will have both deranged. It's not just APTT or PT. Okay. So apart from coagulopathy due to clotting factor deficiency, there is no condition in which you will have only APTT deranged and PT normal. Okay. Yeah. So I will still go with this in there. I would have done maybe a PCR of the dengue, but it's a good case to present. This is HLH. Whether it is because of EB alone or the clinical picture looks more like a dengue encephalitis only and a dengue multi-organ failure. This is not dengue shock, but dengue virus per se inducing. And in fact, a lot of studies are going on this. Dengue per se is known to cause hyperperitonemia to the tune of 20 to 30,000. At times we have seen 50,000 and we have not reacted. One of the papers show that your ferritin upregulation, the gene required for that, it has got a genetic mimicry to the dengue virus. And by virtue of dengue infection itself, the ferritin levels can be so high.
Yeah.
And there, how to determine whether it is HLH or not. So you have got two or more organ affected dysfunction along with the dengue setting, then you label it as HLH. If you don't have an organ failure and just a virus, then you don't label and don't treat it as HLH, just wait and watch and majority will settle down.
Even dengue can present as atypical hemolytic anemic syndrome.
Yes.
So cases have been, so it can be a mimic of so many things.
Absolutely.
So infectious mononucleosis, there were no clinical findings to suggest that.
Yes, this case setting is not like, as I said, as sir said, it's usually a prolonged subacute disorder with tonsillopharyngitis as common as almost 90% of them will come with that. And subsequently, they will get on to maybe lymphadenopathy, organ failure, and HLH will come quite late in that, maybe second, third, fourth week. not on day 4, a bit unusual to explain on that. So I'll still go in this case at dengue encephalitis only and the presentation. You got a chance pending of EB virus positive, but I would have done
I
a
also
dengue
agree with you,
PCR.
sir.
Yeah,
I
I would
also
have
feel
gone with,
strongly it is dengue and
Yeah.
not
I would have
infection,
done a
because
dengue PCR in this child.
infection mononucleus will not present with bleeding tendency. So
Yeah,
this
yeah. Right? Good case, very good, very nice
Yeah.
presentation.
very interesting
Good, keep
case,
it
well
up.
presented and well
Improve on
discussed.
the presentation further. Keep reading. When you are presenting, start reading also. So you'll enjoy it furthermore. You will be good learning experience. But you did well. You did very well. Dr. Snehal, you are there?
Yeah,
हाँ सर सॉरी
hemophagocytosis.
जरा उशिरा जॉइन झाले सर इथे बॅकग्राऊंड नॉईज खूप होता ते
No issues. Satish and Snehal, you can take over. Sir, Dr. Srinivasan sir want to make some comment finally.
Yeah. No, of course, they have made the bone marrow has been done.
Yeah.
So it shows typical this hemophagocytosis we have.
Now, in fact, we do bone marrow essentially when it is, because you have to, when you label HLH, it's 5 out of 8 criteria to be fulfilled. Of those 8 criteria, 2 are ones which are very difficult. So one is CD25 and the second is NK cell activation, right? So those 2 are out. So out of 6, you have to define 5. Or if you're thinking of primary HLH, then you should do a genetic workup. That single positive criteria is enough to diagnose. You don't have to fulfill 5 out of 8. So here, perhaps you're fulfilling 4 out of 6, which is okay. Maybe you can dig it further and you can get it. And for that, you have this macrophage additionally. But alone having macrophage without other features is not a HLH. And not a defining macrophage, but still having 5 out of 8 is HLH. So quite often nowadays, many people would skip this. Only reason why I want to do bone marrow in this child, because I'm going to give Dixa, and I don't want to miss out on leukemia if at all I'm missing. So only a definitive reason I want to do a bone marrow prior to giving steroid for HLH is to not to miss out on a leukemia. Otherwise, you may skip if you are very sure about it. Sir, please.
Yeah, absolutely correct. Yes. Before steroids, definitely a bone marrow is important. Because
Right, Satish, you can take over. Thank you.
Yeah, nice, very nice. I think most of the points are covered now. Any further follow up of the patient should be actually conveyed, because we have to take the last cases also. If anybody wants to do follow up, we can just come out with that, because if the cases are present, we should also get follow up of that patient also. I think good presentation. We can end the meeting now. Sneh?
the only thing, infectious mononucleus will not have this bleeding tendency. And another thing is, of course, usually they don't present as encephalopathy like presentation. Usually there will be lymphadenopathy and this thing, marked lymphocytosis. So of course, it can be a wrong this thing also. Many times, infectious mononucleus can be mistakenly this thing seen in the laboratory. Yes.
Right.
सर
Okay,
थँक्यू
thank
मोहिते
you.
सर अँड
Thank you.
श्रीनिवासन सर
Very
because sir
good
was
case.
not there मला
Very
to remind
informative.
joining sir and nice case. Yeah, thank you. And
Any
whole
comments, sir? Dr. Snegal?
yes sir.
Sir is asking about genetics with HLH, I think.
Yeah,
Sir,
well,
actually,
yeah.
sir has explained, I think, Mohite sir, that primary and secondary HLH. So
Yeah.
whenever, as sir has said, the criteria for HLH, and when we suspect, we can actually, in many of these patients, we have started storing DNA in critical patients also when we suspect this.
Yeah.
Once we fulfill the
Yeah.
criteria and do genetic investigations. Yes, sir. Thank you. Nice presentation.
Yeah,
Thank you.
nowadays,
Thank you.
nowadays
Thank you very
everything
much.
is gene.
Yeah.
Yeah.
Thank you very much. Thank you. Good night.
Thank you very much. Yeah.
Thank you.
Thank
Thank
you.
you, Srinivasan
Thank
sir.
you, Mohit sir.
Thank you,
Thank
sir.
you.
Thank you very
Thank
much.
you. Thank you very
Thank
much.
you, Srinath.
You have discussed it very well. Thank you very
Thank
much.
you, sir.
Thank
very much.
you, postgraduates. You have done well.
Yes.
But only thing request is talk about growth always when you talk
Yeah,
about
put a growth
development
chart.
in the
Make it a
history.
point. Put a
And
growth
this
chart.
child definitely
Huh?
was not growing well, thriving
Yeah.
well. And
So,
this
growth
thing
chart with
also
the
examine the fundus and throat regularly whenever you find a multi-system disorder. Yes.
growth chart
Thank
with the mid-parental height. You will make a habit and you will learn it better. It's a good learning for ourselves. You make that habit, That will be very, I can tell you after 30, 35 years of practice,
And
that's
never
one thing
mention
has
vibration
cracked so
sense
many
and
diagnoses. A good growth
vibration
chart.
position sense you need not mention. Hardly you examine that in a child, yes.
Okay. Thank you very much. Good
Thank
night.
you, thank you very
Indian
much,
IAP.
sir.
Thank you.